Okay, welcome to Think and Drink number 5. This is imaging. Decided to make this a little more official with the slides now, and just everyone can see what articles that we're going over today. And yeah, I think I'm really excited for this one because the articles that we came up with to share with you guys, it really does look at all the imaging techniques as a whole and just comparing on how do we utilize them in our practice. So I'm going to be doing the slideshow format from now on, just so we can kind of stay accordance to the BOC approved provider guidelines. So course objectives, okay, you guys can see that. So for every Think and Drink and Think Before We Drink, so these are usually on Tuesdays. And that's usually more led by Ross Nakaji and more physical therapy driven. But the objectives are going to be the same. We're always going to be discussing about a current peer-reviewed journal article related to sports medicine with other fields of healthcare professions. We're going to critically evaluate the evidence discussed in those peer-reviewed journal articles. We want to compare the evidence to our clinical practice and see if we can bridge any of the performance gaps that we've identified before the session. So in essence, we want to make sure that these sessions kind of change your way of how we practice as athletic trainers or physical therapists or any other profession that's in the sports medicine realm. And we want to make sure that we always get better each and every time. Okay, and last but not least, let's drink and think responsibly at the same time. So this is so in all good intention, let's just have fun. You know, we don't know what everyone's gonna say, but it makes it interesting. I mean, everyone's got something to say about certain things, and it's good that we share and kind of and listen to each other. So so yeah, that's the premise of our Think and Drink and Think Before We Drink sessions. Okay, so we obviously have no disclosures. Okay, this is all just for fun. These articles are all free access. If we did get paid, I don't know what's gonna happen, but yes, no disclosures whatsoever. Okay, I know we got a couple familiar faces here, so and we got some people that are new. So let's just go around and introduce ourselves. I'll go first. My name is Philip Ting. I work at Los Gatos Orthopedic Sports Therapy as an athletic trainer, and I help out at Willow Glen High School.
I'll go ahead and go next. Scott Zimmerman, athletic trainer at Archbishop Midi.
I'm Chelsea Waldrop, formerly Chelsea Blom. I am an athletic trainer at Archbishop Midi with Scott.
Paka here. I'm also an athletic trainer at Los Gatos Orthopedic Sports Therapy. I'm working at San Jose High and Santa Clara Aquamate Synchronized Swimming Team and San Jose State Swim and Dive Team.
Hi, I'm Audrey. I just graduated from an MSAT program at CBU, and I don't have a job yet.
We'll jump out there. What's up, guys? I'm new. I'm Josh. I'm an athletic trainer down at San Diego State, working mainly with football, but I also have men's and women's tennis as well. And I interned at the 49ers with Phil like 5 years ago now. So it's been a good ride.
Hey everyone, my name's Jessica. I am a physical therapist and I'm the current sports PT resident at Los Gatos Orthopedic Sports Therapy. This is my first time to think and drink. I've been going to think before we drink. So happy to be here. Thanks for organizing, Bill.
My name's Abdul. I'm the incoming sports resident at Los Gatos Sports Therapy, and I'll be honest with you, I was confused because the names are so similar, so I thought this was a typo. I thought it was going to be the same thing, so. But this is also my first time. I'm glad to be here. Thank you.
Then Isabel, would you like to introduce yourself? If you're there. Okay. All right. So let's keep going. So hi Isabel, if you're there. Welcome to our Think and Drink session. So we're gonna move right along ahead. So if you guys have a drink, today I'm going a little different. I'm just bringing a cup of water just because it's really hot outside. But let's all cheers to a good session. All right, cheers everyone, and let's get this going. All right, so the very first article that we're going to talk about is improving diagnostic accuracy and efficiency of suspected bone stress injuries. There's an algorithm and a prediction rule that goes with it. So this was done by Dr. Nye and his colleagues. And what I really enjoyed reading this article because it really did go over a lot of the different tests that they used in the past. They were comparing x-rays to bone scans to MRIs and CT scans, and just I think what was really nice is that there wasn't really a way of saying which one is better for these stress injuries, but they all have their time and place just depending on when this bone stress injury is first found. So what I really liked is what they talked about with all the different methods of imaging. And then when they went into just like why they decided to go into researching all these different methods of diagnosing the stress fractures, I mean, they came up with the purpose of why, and they wanted to really see how they can better identify these bone stress injuries without having to lose any time with the military, and seeing that there's a huge discrepancy with the U.S. military and the training, how the training regimen has not changed, but the candidates, like the people that are the recruits that are going into military training, they're coming from a generation that's become more sedentary. So we're going to see a lot of these different bone stress injuries. And so after going through all these different statistics and seeing what imaging technique was useful during diagnosing bone stress injuries, they came up with an algorithm. So let's see if I could show. I'm going to stop share real quick. So they came up with this algorithm right here, just saying, well, if you notice the bone, if you know the bone stress injury and you're able to score it, what do you do next? And there's a really nice flow chart and what you would do for each step. So say if you had a bone stress injury score of at least 4, you would first order x-rays, restrict impact activities, give crutches, non-weight bearing, and then after that, then what other imaging would you order after 3 days? So would you order an MRI, things like that. So from there, I do want to ask you guys a couple questions. Okay, so from here are 2 questions I want to ask you guys. So in your clinical setting, how do you educate your patients if you're suspecting a stress fracture? And what are your thoughts on the stress injury algorithm proposed in the article? If anyone wants to chime in.
I'll go ahead and talk a little bit on that. Just educating them. I think a big part of it, if we go back to our evaluation stuff we were doing last week, history, right? looking at their history of their running, how much what's their mileage at, what's their shoes at. I can relate to the article in the military and how people are coming in sedentary. It makes me relate to my track team and my cross country team, because that seems to be the kids that we get a lot, right? But educating them on the risks that are involved and what's going on with that, I think, is important. And having them understand what's going on, I think that's important on that.
Right. Yeah. I always feel like when there's a patient that is dealing with, like, let's say someone comes into your clinic and they have this nagging injury, and right along their tibia, there's just this one spot that's just nagging them. And you go through their history, and just based off of the impression, it's okay, maybe they are dealing with a stress fracture, and just trying to tell them what to do exactly, because it's nagging every time they take a step. It bothers them, but how do you get them through the process? Like, sometimes I feel like as a patient, it's always just, it's nerve-wracking to know, like, okay, I got an x-ray. Sometimes it doesn't show up on the first initial visit, but they still have this nagging pain, and sometimes it get progressively worse. Like, what do we do in that case? So I think with this imaging, I feel like it's a good way to tell people, well, maybe that, like, it is expected that the x-ray is not going to show up, not going to have any results for the first couple days, due to the healing process of the stress fracture, or how it presents itself. But knowing that there's an MRI available, or even using an ultrasound, right? Those are other methods that we can try to really hone in on our stress injury diagnosis.
Maybe I missed it on the article. How do you rate the bone? Was it the bone stress injury? How do you get that number?
So in the article, they have a graph they have a little text box that says how you can score different risk factors and symptoms. And I think just based off of the evaluation, you would just put a point. Yeah. So for example, like the risk factors, if they had a poor baseline aerobic fitness, I think being a female would also be scoring a point for the risk factor. If they had a history of a stress fracture, any vitamin D deficiencies. So with the risk factors, it's more of just looking at, like, your female athlete triad, or your REDS deficiency syndrome. And then symptoms as well, like if it's a gradual onset of pain, any night pain, things like that. And then when it comes to the exam, it's everything that we would find objectively. So if we were able to pinpoint those in our exams, then our suspicion for a stress fracture or a stress injury would be high. And then that's when we would go through the bone stress injury algorithm.
Gotcha. Thank you.
Yeah, it's in that blue box with the diagnosis. Yeah.
Right.
Attention to detail.
Yeah.
God.
I know.
Fail.
Have you guys seen a lot of bone stress injuries in sports that are not endurance based?
No.
It's mainly our track and cross country
It's
athletes.
mainly track and cross country.
We have had a couple stress fractures, like PARS stress fractures for lacrosse kids. We had one lacrosse kid, just from the rotational aspect of it.
Didn't we have one basketball too? Didn't Sienna?
Yeah, I think so.
For her back, yeah, it was. Yeah.
So that was two.
But it also has to do with posture too. Like some of our kids have horrible posture in their back, so.
We ended up having one with football this year. stress. I think we ended up catching it right before it turned stress fracture. I think the docs ended up calling it stress reaction, but the kid was a wide receiver for football. Ended up getting shut down in the fall. Man, it was like a solid 6 weeks. He basically didn't finish out the rest of the year. He got to go on the bowl trip and just kind of hang out because he couldn't practice.
Uh-huh.
Yeah.
Wow. So then how would they, so in that experience, how did the doctor, or without using like imaging or anything, how would you tell if there's like a stress reaction versus a stress fracture? Or was it just something like you needed to have imaging?
We shin pain, couple weeks. We kind of tried to get him through it before we like jumped the gun on getting any imaging done because I think honestly we were kind of afraid what it was going to tell us. And limited his reps a little bit. It got better for a few days and then it didn't get any better at all. I think at some point he saw a gen med doc in there too. I'm not sure if we did meds. I can't remember off the top of my head, but got worse to the point where he was barely running. It was really bad. He was a big scout team guy, so he took a lot. I think we went the X-ray route. He saw our ortho. I want to say we got him. We just went to an MRI, and I think that's where they got the stress reaction from the imaging there.
Right. Do you guys feel like the MRI method is just not well known to diagnose stress fractures? Like I felt like it was just last year that I just realized, oh, you could definitely utilize the MRI to look at stress fractures.
I was always taught that bone scans were your most accurate way of doing that.
Mm-hmm.
And maybe that's a little bit old school. And after reading the article, I didn't realize bone scans took so long, but they mentioned like 4 hours or something like that. And you have a huge amount of radiation that you're enduring with them. So maybe bone scans, I think MRIs are probably the best option.
Yeah, I think that was definitely a good takeaway point. I mean, yeah, with the bone scan and just knowing just some of the disadvantages of using a bone scan as opposed to an MRI. I thought I didn't realize like how effective the MRI was for this kind of scenario. And I think that just it kind of made me think of like all the times that I would approach a high school kid like, oh, maybe we should get x-rays or we need to go see an ortho or things like that. And they would just do like that initial x-ray and yeah, just never really thought of utilizing the MRI. Especially with the MRI, you can look at any bone edema or anything, any sort of like metabolic buildup that's that could be associated with that with the stress injury. Yeah, any other thoughts about this article?
Well, I'll just chime in for my 2 cents. Like, I also was kind of surprised about the MRI thing. I don't know if it's just I wasn't taught it or whatever, but even on the BOC, I just took it and they're still having questions that say the bone scan is the most accurate way to diagnose stress fractures and stress injuries. And it's like the best way. So,
Wow, yeah. Right.
Old school.
Yeah, it's going to take how many years to change some of the clinical education from there?
Philip, in your experience, have you seen ultrasounds used on these at all?
So
I don't know if I have.
Yeah, I don't think I have. Or maybe
more soft tissue.
Yeah, maybe just more like I haven't had a case of someone using an MRI, but I think just based off of what like the orthopedic surgeon would say, like if they already did suspect like a stress reaction, they would just hold them off and just see what happens after 2 to 3 weeks or so and see if anything changes. They put them in like in a boot or something that's just non-weight bearing and go from there, rather than just like it almost seems like they're sure of it, but they're kind of going blindly into it in a sense. But yeah, I haven't heard of anyone using an ultrasound. or anything. But what I do like is that if things don't resolve, then there's always a backup solution with the algorithm, especially when they do talk about like the CT scan and seeing, and just seeing like if there are still problems, then maybe a CT scan might rule out or might confirm a red flag that that we may have missed that we can't really see initially. So I thought that was a pretty good call with this algorithm. Right. Okay, so anyone else wants to chime in about this article? All right, let's move on. Okay, so this one was comparing the MRI and an ultrasound for the shoulder. So this one was done by Dr. Levine and his colleagues, and they're looking at rotator cuff injuries and comparing the MRI and the ultrasound imaging. So what I found interesting was how wide of a range of accuracies there were for the ultrasound and the MRI itself. Like there were a lot of different systematic reviews done on both the ultrasound and the MRI. So let's see, there was one. So there's a sentence right here. It says overall reported sensitivities of ultrasound for the diagnosis of rotator cuff tears have ranged from 33 to 100%. So that's a really wide range for sensitivities. And when it came to the MRI, they found that reported sensitivities and specificities. Oh wait, hold on, I read that wrong. So from there, they still showed that they had like the ultrasounds and the MRIs, they had similar accuracies, but they're still wide range. So they're going from 60 and 100% for the sensitivities and specificities. So there are a lot of studies on here that were done on the imaging of the shoulder, but it seems like the studies were kind of all over the place. So what they did kind of mention in the article too is what the MRIs and the ultrasounds are good for. So there's a table there that shows like the MRIs, they have an excellent application to looking at the labrum, the articular cartilage, bone marrow, deep soft tissues, whereas the ultrasound you can see foreign bodies or any of the, if there's any cysts, or you can even do dynamic imaging, so you can have them move while you have the ultrasound head right on the part that you're trying to scan. And then what's good with both of them is that you can look at any tendon abnormality between the two methods. So I thought this was a very interesting article, to say the least. I think I felt like the article was leaning more towards the ultrasound just because of its convenience, and it's not as expensive, and it doesn't take that long compared to the MRI. So my two questions for you guys is, if you owned your own orthopedic clinic and can only choose one diagnostic device, what would you choose?
Does our budget cover that ultrasound? $40,000 plus?
So let's say you had unlimited budget and you had to choose only one diagnostic device.
And that's
we're going
one
ultrasound.
For one injury or for the entire body?
The entire clinic. One device to confirm your diagnosis.
I think.
Yeah, but where would you put that MRI machine? It
I
takes
have
up a lot of space.
I'm going to have a massive clinic. No, I think at San Diego State we don't use a lot of diagnostic ultrasound, but at the last two places that I worked, we use it all the time, and I thought it had a lot of benefit. But I think that there definitely is a lot of, and I think it touched on it here on the Observer, I think they called it, but the variability between people that are truly skilled in reading diagnostic ultrasound is very vast. Now that being said, reading an MRI, you never know what the radiologist is going to see either. But I don't know. I think overarching, I think I would rather have MRI in my clinic than an ultrasound if I had to choose. Now they're nowhere near the same comparable in prices and everything else, and size and square footage, but yeah,
Right.
that's my 2 cents.
Yeah.
I think the ultrasound is super convenient, like in a small setting. I think that's nice, kind of confirm some stuff. That's awesome. But again, accuracy of who's using it and what's going on with it too, and then reading it too. Actually, tons of MRIs, and I don't know. Oh, I think I see this, but I don't.
Right. Yeah, I would still have to. I feel like the first thing I would do is make sure I hire a well-versed sonographer, and then maybe choose someone, and then maybe purchase a diagnostic ultrasound, or vice versa, just going with a really well-experienced radiologist and making sure that it's never had any bad experiences or anything, and then maybe go with the MRI. And just depending on where I'm at with the orthopedic clinic, I think that's where I'd go with for sure. But yeah, I think that does lead into my second question. It's like, can you still trust a sonographer doing an ultrasound? And I think we kind of alluded to that, just saying like, well, it's kind of loaded and we don't know. Like, you have all the training in the world and being able to feel like you've mastered using the diagnostic ultrasound, but at the end all be all is just we make mistakes sometimes, and we might miss something that was there. So yeah, I just felt like I found it really surprising that the MRI and the ultrasound accuracies were similar, but it's still like a really wide range. But I'm not too sure, because I think in this article they were talking more about the rotator cuff injuries, but I do want to hear from you guys what's your guys' take on utilizing these imaging techniques for, let's say, rotator cuff tears, and what your guys' experiences are with that.
I know our docs have one, and we brought one. And I remember we had Chelsea, I don't know if you were there. Didn't we have a kid with a possible UCL? Wasn't it Zach or somebody? And being able to see like the dynamic part of the ultrasound and the stress on the tissue. And we even had an Achilles tendinopathy too, the same type of thing. When you see that stress on the tissue, I thought that was pretty interesting. To me too, like, this is pretty new technology. Everybody's, our docs are good with it, but some of the fellows aren't quite as good at reading it too. So it shows that disparity there a little bit too. How good are they at reading all these things?
Yeah, and then we also had another situation where girl was having a lot of pain. She got an MRI, got it read. They said, oh, it was bone bruise, but she was continuously having pain. So we had our docs look at her and do an ultrasound, and he was like, no, like, you tore your meniscus, like,
Oh, wow.
point blank, like, there's a tear here. And he even looked at the MRI too. And then she went back to Kaiser, and Kaiser was like, oh no, you have plica stuff. And they're like, okay, well, why didn't you tell me in the first place? So, one isn't better than the other, and it's all doctors saying this, but the sonographer is saying this, but then the other doctor's saying this. So it's almost like you can never get a straight answer almost,
Right. Yeah.
How you interpret something.
Yeah.
Yeah, I mean, even something as simple as X-rays here on campus. Like, we're pretty lucky. We just get to send them over to the student health center, and it's part of their student fees here on campus, and they go get their X-ray here on campus. But the radiologist that reads it through student health, we've had a couple bad. They have a couple different radiologists, but we've had a couple bad instances where they've completely missed something. So our orthos always double read and just ignore the actual report from the first read, and we go with what our orthos say, because there's been some stuff where like, I don't know how they missed this kid's, clear fracture in this, whatever it was. So
Right.
it's all over
Yeah,
the place.
Yeah, it's crazy. Like, and it's interesting where we send them to. So we had one kid this year. We had this one kid sprained his ankle, but they went to urgent care and they did an X-ray with them, and at first they were like, "Oh, it doesn't look like it's fractured or anything. There's nothing that I see on the fibula." And then all of a sudden, 2 hours later, the doctor calls the kid's parents again and say, "Oh, by the way, there is an actual fracture on the fibula." And then it's like, "Wait, what? What's going on?" So for a while he was booted, and he was just wearing the boot for a whole week. And then all of a sudden they go see the orthopedist, and they're like, oh, they look at their x-ray again. It's like, oh, but there was actually no fracture whatsoever. So there was just like this huge flip around, and the kid was just like frustrated. It was like, I don't know who's reading the x-ray or what's going on, but it just wasn't fair. Like, it's just a lot of false positives, and it was confusing for them. But yeah, it just comes to show that, like, it doesn't really matter what the research says. It's as long as you have someone that's experienced behind whoever's using this diagnostic device, and being able to pinpoint what exactly is going on. I mean, that matters most than which device is more accurate.
I think going back to our topic last week, the evaluation part, the imaging is a tool that we can use, right? It's, one part of the tool. It's not always going to give us a totally accurate image of what's going on. We have to use all those parts of the tool to kind of put together the puzzle and figure out what's going on. I think that's important to understand.
Right.
I would agree with that. I think, sorry I'm late to the party, guys, but I think that's first and foremost. I think kind of obviously it's comfort level with each modality, whether you use an MR or an ultrasound. But I think also we kind of forget about how important the physical exam is, right? So it's still a part of what we're doing. And I think it's just a confirmation type thing. And I think also sometimes the doctors, I don't know if you guys have noticed this, we get super dependent on the imaging, and they forget about the testing and the person that's attached to this. So I think that's kind of one of those things that I think it's very helpful to have these, but I think they still need to do their exam, or we do the exam so we can kind of give them some feedback and then use the imaging as confirmation. So, but cool stuff.
Yeah, well said. I think one quote comes to mind, and I don't know if it still holds true. I think something that goes along, like, if you take a really good history, then you don't really have to touch the patient. Do you feel like that still holds true?
Absolutely.
Yeah, I would say definitely to some degree, your history definitely leads you to where you want to go, right? And can kind of channel those things. So a good history goes a long way. Now, getting a good history out of a high school kid, not always the easiest thing.
Yeah, I don't know if she got this from somewhere, but my eval teacher back in undergrad, she used to say that you can 70% of the time you'll be able to predict what's wrong just by the information they give you, the mechanism, the history, everything. So I've tried to just kind of keep that true and really harp that on students that I've had come through the program and stuff.
Yeah.
I think that's something that we're going to get better with this whole COVID thing. I mean, Scott and I have been putting together policies and procedures of how we're going to do things if we come back in the fall. And one of the biggest things that we've been talking about is like taking a good history, and trying to not touch the kids as much as we used to because of this whole thing. So definitely get to use and practice those skills.
Yeah, I feel like, especially during this time, it's like now we're looking at all the screening forms and all the PPEs, like one of the pre-participation physical exams, and just reviewing all the questions like, oh, we got to make sure we have everything on this form, and we can't miss anything at this point due to what could happen now. Especially you can definitely see there's a lot of risk factors that need to be taken into account, and we can't just do it based off of of like an old pre-participation physical exam form. We need to update it and making sure that it's along with current research and what we're seeing now. But yeah, it's awesome. Okay, let's move on to our last one. So this one I found really interesting with implementing or integrating diagnostic ultrasound into the athletic training education program. And I know this article is coming from the athletic training education article, and I think this would apply to also the physical therapy education as well. So in this article, they're talking about how if they were to integrate diagnostic ultrasound imaging into an educational curriculum, how would they do that? So they would want to make sure that, so let me see here. So they would want to make sure that they go through what they call preparation, linking, hooking, engagement, and transfer process, and just trying to get them to be exposed to diagnostic ultrasound and making sure that by the time they get through this entire process, they'd be competent in using the ultrasound to diagnose injuries. But I think this is an interesting plan that they had, but I still don't feel convinced and swayed that that this should be implemented into the athletic training education program. Because my first thought was just imagining if everyone in the healthcare field was able to use the diagnostic ultrasound and they were all doing the same thing on one patient, you're going to get a lot of different people with a lot of different opinions and views on what they're seeing. So I feel like it's going to make the patient care worse. And this is the kind of thing that I feel like a lot of our professions get really excited about different techniques or different ideas to further our profession, but is it really furthering our profession, or are we just widening and broadening the identity of our professions? So I ask you guys, how valuable is it for allied healthcare professionals to know how to read imaging, and what are the pros and cons of integrating diagnostic ultrasound into AT, PT education and clinical practice?
I kind of agree with you, Philip, in that the fact of like, if all of us know how to read it, then there's even more people talking and seeing different things, right? As much as I think it would be cool if I could like look at an ultrasound and know what I'm looking at, I just think that that's just broadening our job and our responsibility more, that I don't necessarily think that we need to be doing. Even like our doctor will come in with his portable diagnostic ultrasound and be like, yeah, I mean, I've seen this, but I haven't. And like, you know, he's really good at reading, but he still like admits like, I don't know everything about this. I'm still learning. So, like I said, I just don't, yeah, it would be really cool, but I don't think that it would be the best idea, especially for us at like a high school level, right?
Right. Yeah.
College level is a little bit different, but high school, I just don't think that's smart.
Right.
Plus, we can't afford it. But
you guys could. You guys are from Diddy.
To me, going beyond that scope of our practice too a little bit, right? We've already talked about just the fact that the last article, the sonographers aren't great with this stuff. So now we're going to throw us into it. I could see possibly an athletic trainer working in the physician's office and maybe doing the setup on that and learning how to place where the sound head goes and all that. I think that works really well. In the high school setting, definitely not. College, I don't know, Josh. Maybe you guys have some input on that.
Yeah, I honestly, I love the idea of incorporating that into the education model. I've heard rumors, or I don't know where we're at in that, but a few years ago they were going to start, and I think they're going to start teaching suturing in the undergrad programs or the master's programs. I love that. Do I know if I would ever actually suture anybody up? I don't know. I don't have the education to do it. It wouldn't be a post-surgical kind of thing, but maybe we're on a trip and there's absolutely no access to a doc or something, and I'm the only guy, and it's like a 2-stitch kind of, laceration. Yeah, maybe I'll button it up really quick, but I don't have that. I don't have that. I don't know. I think it would be something cool, and maybe it's one of those things where you get taught it and maybe you never use it again. But if you decide to specialize in that or go into the clinic or be the physician extender, you have that ability to bring that to, and maybe it requires additional training and certification on the back end too. I don't know. But I think it's a cool idea to kind of at least open the door for the possibility of doing it.
Yeah, I would agree. I agree. I think if it really just depends on the setting where an athletic trainer would be able to utilize the diagnostic ultrasound. Well, my question is how, like, if this were to be in like a standard athletic training or physical therapy education, like how much time would we devote to teaching this? Like, would it just be like an evening seminar, or would we want to have like one class where it's just dedicated to imaging?
Maybe that could be like an elective. Like if that really interests you, then hey, I'm going to take that extra course. Just like right with doctors and their internships and stuff like that, or their residency, right? Or their fellows. I don't know the exact term, but like, oh, I want to be an ER doc. So then they do more time in the ER, or they want to be, sports med, family med. That's where they focus on. So maybe if an athletic trainer is really interested in it, then they take that extra course. So maybe we get like a tiny little blip of it, or like a presentation in class about it. And if it's something that you're really interested in, then you go on to take those courses and get those certifications.
Yeah, and I think you could even do some sort of like, we had advanced techniques my senior year where like we went through really hands-on, like 4 weeks of I asked them stuff and then all this other stuff. Like maybe you had like an advanced imaging class where you went over, I'm not saying be a radiologist, but learned what to look for in your x-rays, in your MRIs, in your ultrasounds, and start to get that kind of base knowledge. I think that would be kind of cool. Yeah. So that's really useful. That's useful across the board. Even if you're never gonna be a radiologist, you're never gonna be an X-ray tech, you're never gonna be a sonographer. Knowing what to look for is really valuable.
I would concur with that too. Learning how to read. Nobody ever taught us how to read MRIs, right? And how many kids do you have to come in and say, "Hey, can you take a look at this?" Sure, I can, but I don't know what I'm looking for.
Right.
Let me watch a YouTube video.
White section over here. That doesn't look good. I don't think
that looks like a tumor. Oh wait, no, never mind.
No. Like, what does WebMD say about this MRI reading? Yeah. What about the PT side? What are your thoughts on this?
Jessica, you can go ahead and go.
Okay. I was like trying to talk and I'd unmute and then someone would start talking and then I just keep going unmute. Anyways, so actually in my PT curriculum, we had I want to say it was like a 6 or 8 week course on imaging where MD radiologists came in and lectured on MRI, CT, X-ray, not ultrasound, but just like they kind of did like the bare bones Cliff Notes version of the technology and what each imaging is used for and how to kind of read them, like T1 versus T2 for MRI, what the white and the black kind of represent. And so we had a course on that. It was required for everyone. But does that mean I am proficient in reading an MRI? Like tons of patients have done that same exact thing that Scott mentioned. Here's my disc. Can you read it? And I look at it and we scroll through the images and lighten it and darken it. And I'm like, I have no idea what I'm looking at. So, I mean, I took it and I get the general gist of each type of imaging modality, but it doesn't make me proficient at all. So I think it's useful just to kind of know like what each one is used for. Kind of like one of the articles was like, which modalities, or MRI versus ultrasound, right? Which one's better at looking at which thing? But we're not exactly going to say to someone, I think you need an MRI, or I don't know. I feel like that kind of goes beyond our scope and say, hey, I think you just need to follow up with the doc and get, further evaluation. It kind of steps over the boundaries of, we can't really recommend that unless you're in the military where they actually do have those privileges where they can order MRIs and x-rays and that sort of thing. So there is a trend towards that because the military PTs are actually doing that. But in the outside civilian world, that is not something we do. So anyone else want to jump in on that?
I'll throw that in there. So I think that's the biggest difference that they kind of distinguished between the masters of physical therapy and the doctorate of physical therapy was elective courses in things like imaging. So when I went to school, you didn't have that. That wasn't in your lane, right? So, but do we still kind of get them shown to us, or do we check them out once in a while? Absolutely, right? So I think that what it kind of comes down to, whether it's an AT education or PT education, I think it's just to be able to expose you to it so you don't completely look at it and go, I have absolutely no idea which is the femur or which is the tibia, right? I mean, you at least have an idea of your anatomy, right? So I think those kinds of things, but when you start to kind of, it depends again, like on the setting. I think we aren't going to be ordering them per se, right? So do we need to be completely proficient? And probably not, right? But I think in the PT world, it was kind of sold as that's what is going to, again, differentiate a DPT versus a non-DPT, was the additional elective courses that kind of escalates that level of education. To be honest with you, I don't think it's any different what Jessica just said about what she learned in her DPT education from what I learned 25 years ago in a MSPT education. I think it's just another way for the schools to add some more shit and some more ways to add on tuition bills. I really do. I honestly think that's really what it's kind of come down to. But I think, is it helpful to be exposed to it? Absolutely. Absolutely. But the reality is where we are in our profession today is it's not necessarily a big part of our practice. So kind of getting back to what Scott was saying is, is that something that you can get proficient on by doing one or two of these, seeing an image one or two of times a month or a week? No, you get proficient at it by doing 100 a day, so I think that's kind of where, you kind of have to start thinking about, our professions and where do they lie in that healthcare and allied health kind of lines, and where do we help out, where do we not help out? So I think as part of an educational program, absolutely, for the exposure and to learn the basics is excellent, but to become proficient in it, absolutely not. No, I don't think it's going there. So
yeah, I think it's important to really tell the student, like, this class is obviously not going to make you an expert in imaging or any way, but I think it's also just, it's good to know what you're exposed to, so when you're talking to someone who is doing the imaging and you're able to, it's like you're kind of catching up to them and being able to stay on the same page with them, but you're not necessarily overstepping your boundary per se. I think one question that just came up in my mind too was just, with introducing all these different electives in our professions, are we devaluing other healthcare professions during the process, or are we strengthening our relationships with other healthcare professionals?
I'll go there. I'll step in that pile. I think it all comes down to who's teaching it. If that instructor is letting you know that this is to open your eyes and broaden your experience to be able to identify what another field is doing, so therefore you can communicate with them better, absolutely, it's I would say it's an integral part to add to the program. If they are saying that this is what's going to differentiate you from someone else, that by being able to do that, you're going to have a better education and you're going to have more clout behind your degree, I think that's BS. I think you kind of have to really look at the instructor that's really kind of what they're putting the value in it. Because I think that if people do come out of there thinking, well, I should be able to be proficient in this, and this is what makes me whatever, with athletic training now, it's going to be a master's. With physical therapy, it's a doctorate. I don't know if that necessarily does make someone a lot better. Does that make sense? So again, I think it could be a very, very valuable thing if that instructor says, hey, this is for you to be able to bridge the gap and be able to communicate with doctors, be able to communicate with the radiologists, and be able to at least bridge the gap there, but it's not going to make you by any means proficient in any of this stuff. So.
Well said. Well said.
Yeah. And
Go ahead, Josh.
Sorry, Scott. I think kind of piggybacking off that, there's a certain level of bridging the gap there. Like you hopefully communicate more thoroughly with or whoever you're seeing based off of that. But then that also pops into my head is like, we as athletic trainers, PTs, we have a pretty good strength and conditioning world, and I know too many athletic trainers who love to overstep their bounds in that and think that they're completely proficient in strength and conditioning without having any of the other CSCS or CES or CSCCA, all that other stuff that you can get. But the whole idea of having it in our scope is to, be able to have those talks and communicate with our strength staff. And it makes me wonder if it would start to go the other way and people would be like, well, I had a class in ultrasound undergrad, so I can handle that, or, I took an 8-week course in casting. It doesn't mean I'm going to be better than the guy who's at the ortho clinic doing the casting single day and that's all he does. Like, can I make one? Do I make them? Yeah, but am I as good as him? Nah, there's no way. It's what he does every day. But
just to summarize both your guys' points, understand your limitations, understand what you can and can't do. We don't want to step on anybody's toes, right? We got to kind of know what we're good at and be good at what we're good at. Don't go over and beyond what you do. And I get in that habit too. I think I can do it. I'm really good at steri stripping. I'm going to start stitching people. Well, I'm not trained yet. So you just have to know what you're good at and not go beyond where you need to go.
Yeah, it was a wise life lesson right there, Scott.
What I'm about.
All right. Okay, anyone else want to chime in?
Scott and I are
Like a
going to
lot-
start practicing stitching each other up,
Oh, yeah. Yeah, how's that going to look? I feel like a lot of bad things are going to happen from that.
Hello, can anybody hear me?
Yeah. Hi.
Okay, I'm so sorry. I gave a whole spiel earlier, and I noticed I was on mute the whole time.
Oh, that's why we're just...
epic
Here,
Zoom
Isabel, why
call.
don't you introduce yourself?
Yes, my name is Isabel Vasquez. I graduated in 2016 and I went right into actually outpatient rehabilitation. So I was in that realm for 3 years. And actually at the beginning of 2020, I was looking into a military contract with MacDill Air Force Base. So I'm actually located in Florida.
Nice.
And so I was looking into that, but then that fell through because of COVID-19. And then I was doing I was an independent contractor with my outpatient rehabilitation facility, and then I got laid off. So right now I'm kind of limbo at the moment. But going on to questions and overall general, diagnostic imaging, it's working in the outpatient rehab where it was half doctor and then PT integrated together. There was just a whole bunch of, this is what the doctor saw, this is what the radiologist saw, this is what the PT is seeing. And it's just, which one do you go with? Obviously, it's ultimately the doctor because, the doctor provides this plan of care, then you follow under the PT. And this is what they're saying. If we become more trained in reading these diagnostic images, are we setting forth our bias to what we think we see versus maybe what the MD is seeing? Then it gets kind of into that controversy. Not saying that we shouldn't know anything about, any kind of these diagnostic imaging tools. We definitely should, but to become more proficient in it, I feel like we should definitely leave that proficiency to those individuals who need to be proficient in it. I feel like we should definitely be aware. And if we want to, I believe earlier there was a woman talking about maybe having it as an elective, as masters, and then going into that doctorate of athletic training. Yes, definitely in the last semester or even the last year, having it as an elective. Hey, do you want to take a class in, furthering your education this way because you feel like maybe you want to be a physician extender, maybe you want to be in collegiate athletics or professional athletics where they're going to use these tools, and it might have to be on your shoulders. You're using, diagnostic ultrasound just to try and do it, and then they're going to go with what you say. If it's not something immediately needs to go to the doctor, obviously you can put the notes and then maybe the doctor will do an overview. But if that's not something that the MD needs to see right then and there, and you can just kind of say, hey, we can manage this, obviously put in the report, then maybe that's in those realms, but not necessarily everywhere.
That's an interesting point that you made. Like, I feel like if we did happen to be proficient in it and we can at least provide an opinion through the imaging, I think it's valuable than not having an opinion at all and leaving the patient kind of in the dark. If that's what you were getting at.
Oh yes, definitely.
Yeah. Okay. Yeah, that was a pretty good point that you made there, Isabel. Let's see. Anyone else want to chime in? All right. So I put this slide up here in case if there's anything else that needs to be said. So it's really that last call for alcohol, and last call for any sort of call. If there's anything that you guys want to mention about anything, just imaging, where our profession is heading, what everyone's up to, anything like that. Yeah, everyone's everyone's pretty quiet today. Well, I do want to say,
Philip, I'll say something. Josh said he's opening up a big clinic down there with the MRI, so he's got to hire us all down there, right? So we got everybody coming down. San
Who's
Diego.
doing that? Wow, that sounds great.
Yeah, we're gonna completely just dominate the San Diego sports market. So you guys buckle up.
There we go.
Relocate. Come on down.
All right. Yeah, I think. What'd you guys think about today's Think and Drink session?
Solid.
Pretty good. I feel like we covered a lot of different perspectives with this, and I think with all the articles, I felt like I learned a lot from differentiating and knowing which method has value in certain situations and which ones you might want to stay away from for the time being. And but yeah, I learned a lot. So let's do this. So let's see, we got 2 weeks from now, we'll have our next Think and Drink. So this will be June 18th. And typically what I'll do is we'll send out an email with to everyone who's participated in tonight's session, and we'll send out a post-session survey. It's going to be very qualitative. Just there's going to be a lot of questions about like what you thought and how this is going to change your clinical practice. And then once we receive your responses, then we'll put together the certificate and email it right back. So yeah, I would hope by let's make sure that we turn in those surveys by the end of next week. So that would be, we'll give you guys 7 days. So by June 11th, if you guys can turn in those responses, then you guys will get your CEU certificates.
Perfect.
Sounds pretty good. All right, cool. Well, thanks again for joining in. We'll send out the next Think and Drink topic on Monday, and then hopefully you guys can come out on June 18th. Perfect. All right.
Sounds
Cool.
good.
Thanks, everyone.
Thanks, guys.
Really appreciate it. You guys have a great evening. Stay safe.
You too.
And I'll see you next time.
Bye.
Thanks.